Good morning, students. How are you all? Are you all happy? Keep safe, be safe, stay at home. Okay, so today we are going to see about Rntcp. In the last class, we have completed core elements phase 1. I hope you are remembering this. In phase 1, the duration is 1997 till 2006. We have seen the following strategies, that is political and administrative commitment, good quality diagnosis through sputum microscopy, directly observed treatment short course, systemic monitoring and accountability, addressing top TB strategy under Rntcp. So these are the basic core element of phase 1. Coming to phase 2, it is starting from 2006 till 11, and this phase 2 is envisaged to consolidate the achievements of phase 1, maintain its progressive trend and effect further improvement in its functioning, achieve TB-related MDG goals while retaining DOTS as its core strategy, mandatory notification of all TB cases, integration of program with general health services, expansion of diagnostic services. So, whatever we have activities, what is being planned in phase 1 is continued with all the activities are being continued and consolidated in phase 2. And whichever areas the lacunae are there, the lacunae are being resolved, and improvement and further improvement steps is being taken for the betterment of the program implementation. And as the MDG goal says about regulation or reducing the TB cases, we are moving along with that with retaining DOTS as its core strategy. So always DOTS is the core strategy of Rntcp program. You can underline directly observed treatment short course. So that we'll see about DOTS in detail in the coming slides. So DOTS is the main core strategy of Rntcp program. Mandatory notification of all TB cases. It is very important that when it is being diagnosed, the health authority, in whichever health center it is being diagnosed, they have to report to the higher authority so that it is being notified, and follow-up is being done for regular supply of medicines and for DOTS patient, for DOTS provider, and accordingly there will not be any interruption in the supply of the medicines, and for regular follow-up is being done for this patient. Integration of program with general health services. So this program is a major core program which is being implemented in general health services, and diagnostic services are being expanded by making the diagnostic microscopic centers in all the blocks, and the quality of diagnosis is also improved by there are various advanced diagnostic technologies are being implemented. Accordingly, the quality of diagnosis of the sputum microscopy for diagnosing TB cases is being ensured correctly. So standard of TB care for all stakeholders. So it is very important that whoever is being providing the services, so the basic, the quality of the services and TB care is being ensured very well. Programmatic management of drug resistant services. So we are not expecting drug resistant. To prevent that, we are providing regular supply of the medicines. Along with that, drug DOTS providers are also motivated for regular monitoring of the patient, and we are preventing this drug resistant. And even though if the cases come, we have the supply of MDR TB medicines, and that also being provided on a regular basis. Single window services for TB and HIV cases. Single window is nothing but all these cases are being diagnosed properly, and whichever patient is being diagnosed with HIV and with opportunistic infection as TB, and they are being provided medications in a single window service. That means both the medicines are being ART medicine and TB medications are being provided in a single area itself. That there is no need for the patient to go to one center to get TB medicines, go to another center to get the HIV ART medicines. So such kind of things are not the medicines will be available for all the HIV patients with opportunistic infection as TB in a single area, and that is called as a single window services. National drug resistance surveillance, so always the surveillance is being done and regular monitoring is being done, which all patients are being landed up with drug resistant. They are being given special monitoring and regular follow-up is done for the patient when they will not land up with other complications. Revision of partnership guidelines. Presently, public-private partnership is very well managed in this Rntcp program. All the people who are hesitant to come to government or to the TB center to get the medications, they can go to all the private hospitals and get the services. In all the major medical colleges, we do have the outlet for this DOTS medicines. Even in our hospital, we have a DOT center is there in our hospital, and a government employee from the TB center is being appointed here to provide this DOTS medicines for the patient. So in that way, the patient it's not compulsory that if I go to TB center, the people will come to know that I am having TB, or when I go to health center, they may think that what health issue I am having. That kind of hesitation will not be there in the private hospital. Also they can get the DOTS medicines free of cost. So that is about public-private partnership in the implementation of this Rntcp program. Coming to the diagnosis of TB in Rntcp, this schematic diagram you have to study by heart. It is important how we are diagnosing TB under this Rntcp program. So if the patient is having cough for 2 weeks or more, then the patient 2 sputum smear is being taken, and in that one smear is positive, then the patient has to undergo X-ray, and if X-ray it is positive, then then the patient is going to be with anti-TB treatment. If the X-ray is negative, then it is a non-TB cases. Suppose if 2 sputum smears 2 are negative, then it may be because of some other reason the patient might have got the cough, maybe because of asthma or any other respiratory issues. Then the patient will be provided with antibiotics for 1 to 2 weeks. If the symptoms persist, then X-ray is again taken, checking for the positivity and negative of the TB. If it is become positive, then that is called as smear negative TB. That means in the smear it is showing negative, but in X-ray it is showing positive. And again the patient has to be on anti-TB treatment. If X-ray says it is negative, then the patient is called as non-TB. The patient has to refer to pulmonologist for some other respiratory issues. If 2 sputum smears, 1 smear is positive, then the patient has to be on anti-TB treatment. That is smear positive cases. Sometimes the X-ray may be negative, then smear is positive, then we can say smear positive TB, and the patient has to be on anti-TB treatment. So this is about the diagnosis of TB treatment. Coming to Rntcp lab network, how these lab facilities are being integrated. This is also important. So we have in national level, state level and district level. In national level we have National Reference Lab, that is called as a Central TB Division. Under National Reference Lab, coming to the state level we have Intermediate Reference Lab. That's coming under State TB Cell we have Intermediate Reference Lab. Under the district level we have District TB Center, which is a most important and active center which is working for the proper implementation of the TB services. So as I told, in Thrissur we have, in all districts we have this TB center. Surely you have a visit to this center, so you will get to know about this more detail. So in District TB Center you have 3 TB units. Under these 3 TB units, each TB unit is having diagnostic microscopic centers, 3 diagnostic microscopic centers. So each TB unit is having 3 diagnostic microscopic centers under that, which ensure the quality of diagnosis of the sputum microscopy. Coming to the advanced technique of diagnostic tools in Rntcp, this is also very important. In last year, we had a quiz program in our college. In that, this question was asked, and even for the Viva also, this question is being repeatedly asked. Which are the advanced techniques for the diagnostic tool in Rntcp? Microcolony detection on solid media, radiometric backtuck 460 TB method, MGIT 960 mycobacteria detection method, batch system genotypic method, polymerase chain reaction, TMANAA